Good day. Give you all a few minutes to settle in. Welcome. My name is Bill Detmer, CEO of Unbound Medicine. I'm a physician, a medical informaticist, and founder of Unbound Medicine. And in case you don't know Unbound, we've spent the last 25 years delivering evidence-based clinical information to millions of healthcare providers worldwide. And today, we're going to focus on a very exciting area that is directly related to mental health and address the information challenges that are faced in that subject area. We're fortunate to have two very distinguished Johns Hopkins experts with us. As you may know, Unbound Medicine and Johns Hopkins work together on the Johns Hopkins Guides, and the Johns Hopkins Psychiatry Guide is one of them. Both of these speakers have been actively leading and involved in these projects. So the first person who we'll chat with is Dr. Paul Nestadt. He is the James Wall Professor of Psychiatry at Johns Hopkins and directs a bunch of different organizations, including the Anxiety Disorders Clinic and the Center for Suicide Prevention. As founding editor of the Johns Hopkins Psychiatry Guide, he and author of more than 100 papers, is very active in transmitting expertise and knowledge to others in a collaborative way. So he's going to discuss from his perspective some of the challenges that are occurring in psychiatric and mental health care, particularly related to workforce issues and the challenges of needing more providers and needing there to be adequate training and education to allow that to lead to great patient care. Then Dr. Yaden, who is an assistant professor and clinical director of the Psychedelics and Consciousness Research Lab at Hopkins, is going to explore a very, very timely and exciting area, the breakthrough treatments in psychedelic medicine, an area where Johns Hopkins is really a global leader. So why don't we get started? We will have a dialogue with each of these folks, and then we'll turn it over to you to ask questions. So Paul, welcome.
Thanks for having me.
As we all have some sense, we're facing a pretty critical shortfall of mental health professional workforce capabilities these days, where demand really seems to be outstripping supply.
That's true.
Mental health is really tied to longevity and quality of life, so the importance of it is undisputable. But the need for care has been building for years after COVID, after changes in our society. And so our healthcare system is really struggling to catch up with the adequate number and type of mental health professionals and the challenges that have to do with education. How is everyone trained to be able to carry out these duties at the right place and the right time? So I wondered if you would kind of share your perspective, maybe even in a story about how you got interested in this and how you see that the changing landscape of mental health care in this country is progressing, and what gaps you see in that we can address with information.
Thanks. Well, I got interested in this along with several of my colleagues when I was in residency. When we were residents at Johns Hopkins, we recognized that, well, what everybody kind of already knew, which is that most psychiatric care actually is happening outside of psychiatrists' offices. This has always been the case. Primary care doctors prescribe the majority of SSRIs in this country. Most therapy is delivered by counselors and social workers, and increasingly by apps. That's been the de facto mental health care system for many years. And we recognize that as residents, even as we were training to be sort of the most trained type of mental health worker, psychiatrists. What's changed is the scale and complexity. So we've had a shortage of psychiatrists forever. There's roughly 30,000 psychiatrists for over 50 million Americans that have some sort of mental health condition. But demand has exploded since COVID. During COVID and working even before COVID, we worked really hard to destigmatize mental health care seeking. So we started to have people that previously would have been scared to ask for help, now recognizing that it's okay to not be okay, and coming and asking for help. And that barrier to care, the stigma of seeking care, I think we've done a lot of really good work as a society breaking that down. The other side of the other barrier is actually having people to provide that care once folks seek it. So that's where we go back to the fact that there are just a limited number of psychiatrists that have the kind of training a psychiatrist gets, right? The 4 years of residency after medical school, often fellowship, lots and lots of clinical experience with very complicated cases. So this creates opportunities, though, as well as challenges. The frontline clinicians that are actually doing this work, primary care doctors, NPs, PAs, therapists, social workers, they haven't had a specialized residency, but they're being asked to manage increasingly complex problems with the training that they do have. And that's where resources like the psychiatry guide can come in, right? Where we have a guide that can bridge this gap to some degree by providing evidence-based practical guidance that augments the clinician's existing knowledge. It's also worth mentioning that we're often seeing people that come to us for help now with a worry they might have a psychiatric condition when in fact they're experiencing normal range of human emotion, grief, stress, disappointment. And it's really helpful to be able to have a guide that can distinguish, well, when is something pathological and maybe requiring a higher level of care, and when is something sort of within the normal range. So that's where the guide came from, and I think that's the role that the guide can play in American mental health care.
Yes, indeed. One of the things that, as a specialist, right, I'm a generalist. I was trained at UCSF as a general internist. One of the challenges is that if some of this work needs to happen with a generalist, how do the generalist handle issues of this type within their wheelhouse, and when do they have to refer? Could you talk a little bit about the common pitfalls of that connection, and how information and other approaches can help generalists do the best job they can?
Yeah, I mean, there are some pitfalls that many generalists make when they're treating psychiatric care because they haven't specialized in that. Nobody can stay up to date on every specialty. So there's a couple things that we see a lot when we have people referred to us to the anxiety clinic, for instance, where I work, or my inpatient service. One of the most common ones is misdiagnosis. So there's often a jump from quickly making a diagnosis so you can get to the treatment, which is appropriate sometimes in other specialties where you can do a lab test and confirm your diagnosis and you're good. Now let's figure out how to treat that hypertension or how to treat that. But with psychiatry, where there aren't lab tests, the diagnosis requires a lot more time. So someone, when I say misdiagnosis, it might be that they're calling generalized anxiety depression, or vice versa, or missing bipolar disorder because you're only seeing someone in the depressive phase. I've seen delirium in hospitalized patients misdiagnosed as dementia, leading to inappropriate facility placements. Families sell homes, and then the person gets better as they're not medicated as much. So diagnosis is key. That's one of the things the Pocket Guide can really help with. The lesson there is just to spend as much time as you can to get the diagnosis right, knowing that there's a limited amount of time when you're a primary care doctor. You only have 15 minutes to try to use what resources you can. We also see, I guess I might call it therapeutic timidity, right? So people will be on a low dose of an appropriate treatment, let's say an SSRI like Prozac, right? We'll see people that have been on a very low dose for a long time, and then they feel like it's just not working. So a patient will show up in a psychiatrist's office after working with a primary care doctor for a long time and say, I've tried everything. I've been on 7 different SSRIs, and you find out they've never been at a therapeutic dose, or they tried them for like 3 days and really they weren't working. So that's another thing, sort of making sure that although you don't go too quickly, you get to a good dose. There's lots of pitfalls, but you also asked about when to refer, how to know, and that's maybe the most important thing. Again, acknowledging that there's a limitation to how often you can refer. It's a workforce shortage for sure. And that kind of decision about when to refer is one of the most important things that the guide tries to address. In every module we have, every chapter on every diagnosis or symptom, we have a section at the bottom that says when to refer, right? We need to be able to figure out, is this complex enough? Is this acute enough? Is this severe enough? So as a general rule, when to refer might have to do with deciding, if I've tried 2 or 3 treatments and they're not working, it's time to ask for a second set of eyes. But it really does matter what you're treating and how you're treating it to decide when to refer. And that's where diagnosis by diagnosis, the modules in the guide can help with that.
Yes, as a generalist, that has always been a big issue, when to refer. Can you give it like an example, take it down to a particular common condition that where you can imagine somebody having, like me, most of the ability to maybe, let's say, get most of the diagnosis right and have a general sense of the treatment plan, but it's getting pretty complex. Like what kinds of things would I learn that might help me move forward in a patient encounter?
Well, I think maybe one of the most common things that we treat is depression, right? So with depression, that's generally, as I mentioned before, generally treated in a primary care doctor's office first. The first line and often second line treatments are applied in primary care doctor's offices. And often that's all that's required. Most people actually do respond to the first or second treatment, even in, so whether that treatment is psychopharmacological or cognitive behavioral therapy, they respond. If they're not responding, and you sort of you've used the two SSRIs that you're most comfortable with, like I know Lexapro and I know Zoloft or whatever, that might be a reason to refer. The other thing is that there's a severity that worries you. Suicidal thoughts are sort of a big red flag that you might want to think that this could use a special. So you mentioned in my introduction that one of my roles is that I'm the medical director of the Center for Suicide Prevention. So I'm very focused on that. And I know that when suicide is mentioned in an appointment with a primary care doctor or with a counselor or social worker, everyone gets very worried. The fact is, most suicidal ideation is not going to result in a suicide, but it's hard to tell when it will and when it won't. And that's when you kind of want someone that has had a lot of clinical experience distinguishing suicidal thoughts from something that might become actionable. So that's another thing. And the other thing is that a specialist might be more familiar with some of the tools you can use when you're worried about someone ending their own life. There's a couple modules in the guide that address specific things like firearm access. We have a module specifically about the red flag laws and how those might exist in your state. They only exist in 22 states, so knowing if your state's one of them. These are laws that allow you to temporarily remove a firearm, for instance, from someone who you're worried might use it to end their life. So things like that really require a specialist that a primary care doctor might not feel comfortable invoking. So that's sort of for depression. But there's going to be different sets of acuity standards and complexity standards for different conditions, of course.
We'll move to bit in a second, but my last question for the setup here, and then we can have other people ask from the audience, is, so this is on one end of the spectrum of trying to solve problems, which is what most people do every day. But then there's also being able to be kind of current awareness, kind of know what's changing, and therefore to be able to know to ask the question is something has changed. So how do you deal with that in your life as a clinician and as an educator and with the tools you use?
So to know when things are changing and when to ask if there's been a change.
Yeah,
So one thing,
how to keep current.
Oh, I misunderstood. I thought you meant a patient. Yes, how to keep current. Well, that's hard. So I mean, it's really it would be unreasonable to ask a generalist, for instance, to read every issue of the American Journal of Psychiatry or any of the hundreds of other psychiatric journals that are coming out, or even the news aggregators that sort of take the top headlines. The fact is, so I'm an academic. I write papers, I do studies. Most of the papers I publish are not going to change practice for the average person, especially someone who's not a psychiatrist. It's really more stuff that's niche stuff. One thing the guide is really good at, because it's electronic media, we're able to sort of update it on the fly. So if something does come up that's actually going to change practice, for instance, when the FDA approved esketamine from Janssen, right, that all of a sudden there was a treatment that was approved for treatment-resistant depression that was really rapidly made available across the country. So we had to quickly make updates to the modules we already had on ketamine as an unapproved treatment. So here's what so you're not gonna be able to read all the journals, but having one guide that you can go to know what the most up-to-date thing is, I think is very useful to have.
Yeah, well, it's kind of have an expert in your pocket or something like that as
Yeah,
much as you
that's a
can.
good way to phrase it.
Yeah, yeah, that's great. Well, thanks. We'll come, I'm sure there'll be other questions for you from the audience, but let's move to Dr. Yaden. Um, this second problem that we've identified is innovations in psychiatry, and particularly for conditions, common conditions that don't always have effective treatments, at least when they get complex, and like PTSD and treatment resistant depression. And so here we are with this very exciting and interesting new area of psychedelic medicine, which, as I said before, Johns Hopkins is really the established global leader in. And Bet, who is an assistant professor of psychiatry, is also the clinical director of the Center for Psychedelics and Consciousness Research. And so that's a pretty interesting area to be in. So maybe you could tell us a little bit, for those of us who weren't trained, I certainly wasn't, in psychedelics in any way, shape, or form as a generalist. Tell me a little bit about, how it's come on the scene and how I should be thinking about it, and how I should be getting informed when my patients often are the ones that are asking the questions.
Absolutely. I think it's a really interesting moment in psychiatry because of the dawn of this kind of new subfield. And I think that there's a ton of confusion about it, which makes it really fun to talk about as an educator. And so where to start? I think the first part of your question was really about kind of how did we get here that suddenly psychedelics are being spoken about in mainstream psychiatry. And it was really about 20 years ago that there was a shift in clinical trial research such that researchers like Roland Griffiths here at Johns Hopkins, as well as some others, began really questioning whether medicines like psilocybin, MDMA, LSD even could have clinical utility. There was a significant amount of clinical research actually that took place in the 1950s through late 60s, I should say. And then in 1970, there was a huge kind of prohibition against psychedelic research that also kind of followed the Cultural Revolution and the Vietnam War and a number of things that were going on in the United States politically at the time, but didn't necessarily reflect the actual dangers of the medicine themselves. And so in the last 20 years, physicians, scientists have really been curious, what are the risks of these medicines, and really getting clear about risk profile, but also trying to understand, are there specific conditions where we find that psychedelic medicines can be useful? And, I should say I'm a psychiatrist. I believe in the many effective treatments that we have in psychiatry for things like PTSD, treatment-resistant depression. I think, one of the things that's so great about the Pocket Guide is that it really features, the tried and true treatments that we've really come to trust. And I think it's important to underscore that psychedelic medicines are really still in their infancy in terms of research, and yet there is a lot of promise. And I think within the next few years, we will see these medicines become available for clinical use. And it's essential that providers, whether they be generalists or psychiatrists or other advanced practice practitioners, know kind of what the potential is with these medicines, but also what the risks are.
Mm-hmm. Yes, I mean, this is not a common situation, probably. I think about it, where kind of the knowledge and the impetus comes from the outside the profession into the profession, even though, as you say, there was research done a long time ago, high quality research that showed benefits. Some people may have read Michael Pollan's book, How to
Yeah.
Change Your Mind and
Yeah.
that kind of thing. And so a lot of people are aware of these findings and very curious about it. So herein lies the essential challenge in medicine and as it relates to society is, how does the profession help to classify and communicate the evidence that's building on this to the profession, at the same time giving the profession skills for translating whatever that evidence is of the day to sensical answers that patients may ask?
I think that's a great question. And I think right now, because, and something I want to stress in our conversation today is that, um, what do we mean when we talk about psychedelic medicine? And so in our guide, we specifically outline 3 medicines that have been used most robustly in the psychedelic treatment model, kind of in current um, clinical research. Those medicines are psilocybin, which is the active ingredient in magic mushrooms, for lack of a better way of kind of situating it, which is mostly what our lab at Johns Hopkins uses. MDMA, which recreationally is sometimes referred to as ecstasy or Molly, but is another kind of medication that's been under investigation over the last few decades. And then ketamine is this kind of interesting case in that ketamine can be used in other areas of interventional psychiatry, and yet also within psychedelic medicine, it's sometimes used in a similar model to things like psilocybin, where the actual subjective effects of ketamine are thought to support treatment outcomes. And so when we think about psychedelic medicine, we're talking about these 3 medicines, and at least currently. And when realistically, while one of those is approved in some cases for use with mental health treatment, psilocybin and MDMA are not. So these are not medicines that are being prescribed currently. They're not available. We can't refer our patients. And so I think it's always essential to kind of start out any conversation about the evidence and just kind of what is the state of the field and how do we communicate about it by saying, these medicines, for the most part, are not available yet. We're still learning about them. I think that being said, there's a number of, I think, really compelling areas of inquiry that I think are worth kind of updating providers about, just because it's useful to know treatments that are on the horizon. And I think because of media outlets and extraordinary writers like Michael Pollan, there's a lot of talk about these medicines. And I think for that reason, all physicians, all practitioners at different levels should be able to answer their patient questions about these medicines in a way that's responsible, because realistically, people are talking about it.
Yeah, it's so interesting. This is not, again, very often the case where you see it coming, and so you're essentially, setting the ground
Yeah.
for those conversations. And people are going to ask no matter what. You can't just say, no, it's not approved, because, particularly for people who are in these categories of illnesses that don't have great treatments, there's a lot of hope potentially, but then there's a balance. So is there, I mean, again, for a generalist who's got a lot of stuff to do, tell me how your guide or your education that you do elsewhere kind of helps guide people that way.
Absolutely. And I think the first thing is just kind of, defining our terms, really just kind of trying to create kind of a scaffolding for what are these medicines. If your patients are, asking about their use for certain treatments, kind of trying to understand where they're coming from. I think another really strength of one of our sections in the guide is talking about harm reduction. I think the reality is that as much as it would please me if patients were only using these medicines in the context of clinical care or in clinical trials, the reality is that some people make choices to use medicines that have not been approved without the oversight of a physician. And I think it's critical that we know, gosh, there's a lot there's serious differences between the safety profile of a medicine like psilocybin versus a medicine like MDMA. And so, for me as a provider, I think it's essential that we educate ourselves about some of the things that can go wrong, and they can go wrong outside of a context of clinical supervision. And so I think it's, as providers, we instill hope. Like, that is what we do. It's such a part of healing in general. And I think there is so much hope to be had in the future of psychiatry as a whole. And I certainly think psychedelics are part of that. And at the same time, I think we have to temper that with appropriate expectations, with conversations about safety, knowing, for instance, in our studies, in any of the studies that you've read about in psychedelic medicine, we are robustly screening our patients for history of psychotic illness in themselves or their family, just because we don't know the full risks of these medicines in folks who may be vulnerable to certain kinds of severe mental illness. And so I think from that regard, it's an exciting time, but one with a lot of caution and need for education.
So I have one more question. Hopefully it won't be a long answer, but I think it could easily be. And
I'll try
it's
not.
so not from you, but from what you hear when you hear it, is that there are people out there who are very well informed, almost as well as the profession, and sometimes sometimes more. And with motivations that are, honorable and looking for benefit. And when it comes to like a Johns Hopkins as a center, as a place of research, as a place of care, how do you handle that aspect, which where there are not that many places to refer or to get involved? And what do you tell people if you're out in the periphery, but you have a highly motivated patient who wants to be part of the science that's unfolding?
Well, I mean, I think that we have a really wonderful center and we have a number of clinical trials. I think last count is 13 active clinical trials, mostly again with the medicine psilocybin. And I think folks being educated about these medicines on their own or through resources like the ones we've discussed today is fabulous. I'm predominantly an educator, so anytime someone comes to me having learned about these medicines on their own, I'm thrilled. And I think that there are some degrees of protection built into our screening practices, specifically around things like vulnerability to certain mental illnesses within one's family. I think also there's the reality that certain psychedelic medicines, there are drug-drug interactions that a layperson, however well informed, may not be as attuned to. There's certain other risk factors, psilocybin, for instance, which we consider as an exceptionally safe medicine compared to some in terms of its physiologic effects, can still raise people's blood pressure acutely during the kind of period of use. And so there are these kind of subtle risks that people may not be aware of that I think our study practices at the very least are very attuned to. And so, if folks are interested in participating in our trials, please go to our website, fill out an e-screener. But again, I think one of the things I feel so grateful for is just the emphasis around safety in our own clinical trial practices. And I really hope that one day then translates to the clinical execution and dissemination of these medicines.
Mhm. Wonderful. Wonderful conversations with both of you to start this, but we're going to get to turn it over to our audience here in a second. One thing I'll just say though is that you can, I think this, now you're me talking and I'm not the expert that you are, but what I would say is, we're at the dawn of a new era where, information access and is going to, accelerate, but that doesn't mean the wisdom that comes along with it will. And so it really does, put a premium on getting ready. Essentially, you talked about a scaffolding or a structure of being able to think about some of these things and know what to trust and where to go to get this kind of information, and also where to refer if possible. And all of that is kind of, as clinicians, I feel like we are, one of our new or expanded responsibilities is to be navigators or guides to people as these kinds of things start to come into the mainstream. So, Ben, thanks for joining us. You are the keeper of all the questions we've been getting. So fire away.
Awesome. Hello, everyone. My name is Ben DeVos. I'm the marketing associate for Unbound Medicine. And first, I just want to thank everyone for tuning in. And to Dr. Yaden, Dr. Nestadt, and Dr. Detmer, thank you so much for such a fantastic discussion. That was so informative, and I'm sure a lot of people found a lot of value in it. We do have a few questions. I believe this one would be for Dr. Nestadt. Are there tips to ensure a smooth referral process from primary care provider to psychiatric professionals? And are there any tips to ensure thoughtful follow-up?
Yeah, that's a great question, actually. So, there's perfect world and then there's what's practical. But I will say that if you can communicate as a primary care doctor referring a patient to a psychiatrist, if you can communicate directly with psychiatrists, sometimes I'll get a referral, there's be like a piece of paper saying like, depression, please help or something like that. It's not as helpful as being able to talk to that primary care doctor and say, hey, what's worrying you here? Like why the referral now? Like knowing what you've tried before, because often the patient doesn't remember everything. Like, yeah, I think they had me on something that started with an L, So if you can have, in a perfect world, a transfer note. When I take patients to the ketamine clinic, we actually require a transfer note that lists all the medications they've had before and how long they were on them and what doses. But having that communication, because there's some soft things that might not be in the medical record that are helpful to get. For instance, hey, by the way, with this patient, the wife is really helpful in providing collateral information. So keep in mind that she's a good person to talk to. So that in a perfect world, that direct communication is really great. And then even better is continuing that communication. So like this, you want the psychiatrist, it's a two-way street. Psychiatrist takes a look at the patient, gets back to the primary care doctor. It doesn't just say to the patient, oh, hey, I think this is this and you should do that, but also communicates directly with the primary care doctor and says, hey, here's what we discussed. And we talked about, I know you were worried about this medication because of blood pressure, but if we do this, blah, blah, blah. That kind of two-way communication. There's nothing that beats that. Yeah, I hope that answers the question for how to do that warm handoff kind of thing.
That's fantastic. The next question is, and I believe this would be for you, Bit, how would a primary care provider recommend or inform patients about psychedelic therapies? Is there a list of licensed providers?
It's a great question. And so I'm going to again kind of treat each of the psychedelic medicines uniquely. And so in the case of ketamine, used in a psychedelic treatment model, and the psychedelic treatment model really just refers to a structure of psychotherapy that includes like really specific kinds of preparation, the day of kind of drug administration, and then a process of integration, which is again kind of psychological support or supportive psychotherapy that often follows the dosing day. So ketamine, for instance, is clinically available. There are practitioners who use ketamine in the psychedelic treatment model. There is not, to my knowledge, a kind of a specific database of these providers, but often certain areas you can kind of Google ketamine psychedelic treatment model. That's not a therapy that we study at our research center, and so I can't speak to it directly. If patients are interested in other kind of more typical psychedelic medicines, such as psilocybin or MDMA, it would really only be referring them to clinical trials. And so there are a number of different research centers across the country, and these are increasing every day, whether it be, big ones are NYU, Yale, University of Wisconsin, UCSF, Stanford. And of course, we like to say that, Hopkins is certainly a leader in this, and specifically for psilocybin research. And so if you Google any of these center websites, there are always going to be a list of clinical trials that you can share with your patients that they can apply for certain conditions.
I just want to mention that as far as registries of providers, for S-ketamine, which is the FDA-approved version of ketamine that insurance will pay for, there is actually a database because everyone needs to register if they are an S-ketamine provider. So if you were to Google S-ketamine provider database or Spravato, that's the brand name database, you can find a map that shows near you where people have registered. Because to give S-ketamine, you need to be registered with the FDA REMS system, so you can find them on a map, which is useful for that particular type of treatment.
And just to clarify, what makes this especially confusing for our patients is that esketamine, which again can be used for the treatment of depression or treatment-resistant depression, can be used not in the psychedelic treatment model. So you could
Yes.
receive this medicine without the kind of specific targeted psychotherapy that we use in our clinical trials. However, if that's what you're looking for, you might want to specify specifically, but that's super helpful, Paul.
No, that's a good point. It's when I'm talking about Spravato, it's without a therapeutic component. It's purely the medicine.
So Ben, let me just suggest that we get some of these links and send those out to webinar participants so they have the benefit of getting a direct access to those things.
Absolutely. I think that's all the time that we have for questions today, but if you'd like to learn more about the Johns Hopkins Psychiatry Guide, Unbound Medicine is offering a 14-day free trial of the Johns Hopkins Pocket Guides. You can sign up for the trial by scanning the QR code on your screen, which will take you to a full collection of the Pocket Guides, including the Psychiatry Guide, the ABX Guide, HIV Guide, and Diabetes Guide, or by visiting our website. Once again, I want to thank Dr. Nestadt, Dr. Yaden, and Dr. Detmer for this excellent conversation. I hope everyone found this information valuable for the future. A video of the presentation will be provided to all attendees and those who signed up for the webinar, so please be on the lookout for that in the coming week. At the end of this session, we'll be distributing a survey, and your feedback is incredibly valuable to us in how we do future webinars. So we would greatly appreciate if you could take a moment to fill that out. In addition to our wonderful panelists, I'd like to thank everyone for joining us today. If there are any questions about this webinar, you can please feel free to reach out to us at webinars@unboundmedicine.com. Once again, I just want to thank everyone for joining us, to Dr. Detmer, Dr. Nestadt, and Dr. Yaden. And I hope everyone has a wonderful rest of their day.